she is presenting a beautiful case of serpiginous like choroiditis in a highly suspicious case of pulmonary tuberculosis.
One. So coming to the case. My patient, a 37-year-old Hindu male from Rourkela, came with a chief complaint of diminution of vision in left eye since 3 months. History of present illness. Patient was apparently all right 3 months back, and then he presented with diminution of vision in left eye, which is painless, gradual in onset, and progressive in nature. A history of weight loss was present, and a positive family history of tuberculosis was present. There was no such significant medical or personal history, and on general examination, patient was conscious, coherent, oriented to time, place, and person, and vitals were within the normal limit. On ocular examination, right eye within normal limit, and in left eye, uncorrected visual acuity and the best corrected visual acuity was 6/18 and near vision was 6/24. Ocular motility full and IOP 13 mmFG. On external examination, face symmetrical, head posture normal, ocular alignment orthophoric. On doing slit lamp examination in both right and left eye, anterior segment was found to be normal. And on doing the detailed fundus examination, right eye was normal, and in left eye, disc edema was noted with multiple heel serpiginous like choroiditis lesions. On investigations, on doing blood examinations, RBS and complete blood count was normal, and ESR and liver function tests came out to be raised. HIB, SBS, AG, and VDRL were non-reactive. On doing optical coherence tomography, cystoid macular edema was present in left eye, and on fundus fluorescein angiography, activity of superior lesions and diffuse capillaritis was noted in left eye. And in endocyanin green, delineation of choroidal involvement was noted in left eye. Non-contrast computed tomography of thorax was done, that is NCCT thorax, and subcentrimetric lymph node were present, largest 5.3 mm. But the quantiferon TB was found to be negative. This is the ultra wide field fundus photography of the patient of the left eye, showing the multiple healed serpiginous like choroiditis lesions and the disc edema in the left eye of fundus. This is the fundus fluorescein angiography picture, and in the left eye, in the later stages, we can see the diffuse capillaritis was noted. So the diagnosis came out to be in left eye multifocal serpiginous like choroiditis, with a differential diagnosis of acute posterior multifocal placoid pigment epitheliopathy, amphigenous choroiditis, multifocal chorioretinitis, persistent placoid maculopathies, and infectious etiologies like herpes virus and toxoplasmosis. Patient was given intravitreal dexamethasone implant in left eye, Orzodex, and bromophenac eye drop was started. Later, patient was started on ATT, and on consecutive follow-up after a month, improvement was seen, and the best corrected visual acuity gradually improved from 6/18 to 6/6 in left eye. And he responded very well to the anti-tubercular therapy with the regression of lesions. So to conclude, every patient with serpiginous like choroiditis should undergo testing for previous exposure to tuberculosis, and anti-tubercular therapy trials should be given if the lesions are found to be progressive and sight-threatening. Thank you.
If you look at the fluorescein angiography, it looks like a frosted branch angiitis. Can you show me the...
Yes, sir.
Yeah. What do you say, sir?
Most of it is capillaritis is seen, and tubercular etiology is, can be there in case of frosted branch angiitis. We have reported a case of frosted branch angiitis. This indicates that the severe inflammation of the posterior segment. Retinal vasculitis is seen, and what is the HRCT chest finding?
HSCT is just lymph node was found to be lymph adenopathy was found.
But I think that lymph
Largest.
Yeah, so I think just such subcentric lymph nodes are not very much significant.
You know that you should consider the possibility of those multitestis positive, even the
That was
possibility of the
negative.
Behçet's disease. You should keep it in mind.
Because
Family history of
the patients can, sometimes what happens that patients can present initially as
With
an
retinal
ocular
infiltrate,
Yeah.
Behçet's can present retinal infiltrate. Can you show the fundus photograph?
Yes, sir.
And this the infiltrative lesions in the retina is suggestive of the probably of Behçet's disease than of
Because capillaritis, it is a feature of, basically it's a feature, it's an important feature of Behçet's. And your patient has actually responded what we, have you done AC tap for the PCR
step maybe that on
No, sir, sorry, sir.
to rule out any infectious etiology? Because we are seeing a frosted branch vein injected type of picture which is also closely mimicking as Behçet's. And since you frosted branch vein injected, you will have to rule out infectious causes. It is better to do a AC tap to rule out some viral infection or something. And those lymph nodes, that if the lymph nodes are less than 1 centimeter, they are not significant. They can be seen even in us.